But no, it had nothing to do with teaching status. So then the question was, maybe they have sicker patients, and we have to pay more for hospitals that have sicker patients. That would make sense. But no, it had nothing to do with the sickness of the patients. Well, maybe their costs are higher. Some hospitals have to pay more in salaries, and they have to pay more because they're in an urban area or whatever. The difference had nothing to do with cost. Well, maybe it had to do with Medicare and Medicaid. You know, hospitals get underpaid by Medicare, underpaid by Medicaid, so they have to charge more for everybody else. It had nothing to do with Medicare and Medicaid. It turns out in Massachusetts, our competition, the hospitals that charge the most, the reason they charge the most is only and solely because of their geographic location or their brand name or their market power. And what's worse is over the last few years, the rich have gotten richer and the poor have gotten poorer.
But Brian, who creates that paradigm? I mean, what I would offer on the other side of that is we have to take responsibility for that. And
yeah.
I grew up in Massachusetts, and I started my career at Harvard Medical School, and I worked at Children's. We love our academic medical centers. And that creates an environment where, to be unnamed, academic medical centers can demand that. And one of the things that and you and I have talked a lot about this, Massachusetts was about individual responsibility and shared problem solving. That's why it's an individual mandate. That really got lost in the federal discussion. And I think Massachusetts is an environment where we are more open to these ideas. But as individuals, we do have to take some responsibility for what has been created. And when I go off and talk to hospital professionals who are on the finance side, they just bemoan the fact that they deliver outstanding care, and they can't get the insurers to recognize they just get beaten down in negotiations. And so, you know, Brian's right. We are perpetuating the system ourselves. It's just really inherently broken.
Well, and I think to that, I mean, it's sort of what I was alluding to, I think because of these reports, and frankly, I think if you did this same kind of analysis in just about any other state, you'd see these dynamics. Because again, it's not just about the brand name institutions being able to command and get higher prices. And so I think we're having a really robust conversation in Massachusetts, and what I was alluding to is I think this is going to come at the national level about, does the market system, does this competition-based system get us to where we need to be or not? And it's not a black and white answer, but I think the tides are turning. We went through a real period of 15 years ago that was all, let's deregulate everything, and we did. And we're now seeing, whether it's in financial services, whether it's in healthcare, despite historic high levels of distrust in government, I also think there's a frustration and a growing awareness that, you know, the market isn't really working so well either. So where that all comes out and whether we end up somewhere in the middle, I don't know, but we're having the most engaged conversation we've had about these dynamics in this state in 15 years.
Well, I'm going to take over here, Tony, and this woman over here in yellow, and then there was someone here as well. Yes. And that may be all we can take. So, Tony?
Hi, I'm Tony Hayes. I'm the Dean of Nursing, Nursing Science and Health Professions here. And while I really appreciate all the great outcomes that we can anticipate as a result of the reform, and in particular for well people and keeping them well and promoting wellness, and I've heard a lot about hospital care, but the largest growing population of people who are going to be using the healthcare system are the elderly, who already have chronic illnesses and who are faced with a system of long-term care and home care that's broken. And in part, it's because it's been severely underfunded. And I just wondered how you see healthcare reform helping us in that area. Because if we don't invest in those areas of our healthcare system, we will never be able to cut costs in the hospitals.
I'll try to answer that. In fact, I forgot to mention this. When I listed all the different interest groups, the groups that were the least enthusiastic about health reform out of the groups that I listed were the home care and home health agencies and skilled nursing facilities. And compared to the hospitals, for example, they're not as enthusiastic because they're not going to get the patients that the hospital's going to get because they're already getting Medicare and Medicaid. And when 32 million more people get insured, They're going to be younger people, they're going to be people that are not on Medicare and Medicaid, and they're going to be flocking to the other institutions that will get the business. And part of health reform, I mean, you have to look at how it's being funded. It's a $940 billion cost over 10 years. Part of the way it's being funded is by reducing the rate of increases that these provider groups would have gotten over the 10 years. Now, these providers have, for the most part, gone along with that because they are going to be getting new business. 94% of people will be insured. But the group to benefit least are really the long-term care facilities, skilled nursing facilities, and home care facilities. So while the bill does do a lot in terms of demonstration programs that will benefit the elderly, there is this issue of home care and skilled nursing facility reimbursement that continues to be a concern for them.
But
So,
do you want to describe the Class Act? Because that's a really plus, I would think.
it's you might know it better than me, but it's kind of it's almost like an insurance program for disabled people. When I read about it, it actually reminded me of a little bit of what Bob Master is doing.
Yes.
Yeah. Okay. So you may know the details of
Well, I
that.
just think there's a recognition of the point that you made, particularly whether it's the disabled, whether it's just dually eligible seniors with Medicare and Medicaid, that those are in fact some of the, those are really, there's a huge amount of spending and there's a lot of spending growth. And so there's some really innovative models, some in Massachusetts. We were talking about Commonwealth Care Alliance, run by Bob Masters. We have these senior care organization models here, and there are other innovative models around the country. And so again, this is an area in which the federal bill is creating new opportunities to spread those models, invest in new ones. And so I think we'll be hopefully hearing more and developing more that we can sort of grow even further.
I just want to add something to keep an eye on. So CMS Medicaid waivers are traditionally hundreds of pages and horrible to read. But there is a trend that started, and Rhode Island is a state to keep an eye on, where the waiver is much simpler, and it's sort of a global waiver, and the state says, I promise not to spend any more than this if you give me a certain amount. What Rhode Island is doing is trying to move people out of the institution into community-based settings. And Rhode Island, for all its financial challenges, is an incredibly innovative state, probably because they have such a small degree of resources. So that's something to watch. I know a lot of states are seeing if it's something that they can do. Because for Medicaid, it's obviously a huge cost issue. And if they're successful there, I think you're going to think CMS being supportive of that in other parts of the country.
Woman over
Hi,
here.
I'm Noelle Dent, a nurse practitioner student, and I'm just interested in the global payments for the preventive services, because the reality is that nurses generally do that, and I think that that would also be a benefit to the elderly, the increased preventative services that nurses provide. And are any of these global payments going to be, nurses notoriously can't third-party reimburse for our services? Is there any kind of look at providing some of this global payment, not just to the doctors, because the nurses are the ones that are going to be doing this?
Yeah, so I think that's a really important point. The way global payments actually work, and they work, there's a lot of work to be done to develop a kind of common model, but just to sort of generalize about how they work. When I had that slide up that showed this sort of coordinated system, the idea is that it's a payment that's articulated for all of the care, which ranges from home health to nursing to acute care to primary care to rehab, whatever you could need in a year. The payment covers all of those things. And so who would accept that payment is a group of providers working together who can coordinate and provide all of those services. Global payments don't necessarily dictate how those payments are allocated within the providers, and it's in part because it recognizes, just take Massachusetts, we have some traditional integrated delivery systems here. Take Partners, where they own everything, they have all the pieces. We have other parts of the state where that model doesn't exist, and so there's, I think, a desire to create a flexible model where you could also do this on a virtual basis. You don't have to have a hospital that owns a physician practice. Brian mentioned Mount Auburn earlier. There's a model where you have an independent physician organization and a hospital that have come together to negotiate how to share a global payment. So there really is opportunity for innovation, because I'll just be frank, it's not like we've figured this out, and I don't think that there's a one-size-fits-all solution. But at the end of the day, the intent is to really change the game. So under the global payments, we shouldn't be paying nurse practitioners and primary care physicians the fee-for-service rates because it's not going to work. We need to have the flexibility to pay for email, for group visits, for phone calls, and to do it on a salary basis like the folks at Harvard Vanguard, or to do it in a different way. So I think this is why it's great that we've got the opportunity to try different models in the national bill, and for the government to indicate they'll let Medicare play too, so that this isn't just happening in the private part of the market. But there's still a lot we've got to work on.
I just wanted to add that some of these models that are spelled out in the bill explicitly say that there can be non-physician managers of those models. So that's another really interesting change, this provider-neutral language. I think it's a real opportunity for advanced practice nurses.
We have one more question here. Is there, all right, please stand up then and tell us who you are.
My name is Sharon Kubik. I'm an acute care nurse practitioner in one of those academic teaching hospitals. And I'm a doctoral student here. There's been a lot of the language that we've heard tonight, and things that I've read about the primary care providers, but I'm a provider in a medical ICU. Is there wording on how it's going to change our billing practices, and with the new reform, is it going to impact those of us that work inpatient on how we take care of our patients and how things can be done?
There are a lot of things that people have said about national health reform that just aren't true. Particularly in Massachusetts, the average person isn't going to feel much difference. You're going to be able to keep your insurance. You're going to be able to take care of your patients. They're going to be able to keep their insurance. So it's built on the private system we have of insurers and providers. It's not a government-run system. There is more insurance regulation, which is, in my opinion, done to benefit the consumer. But in fact, I don't see what would happen to you in that setting. Again, hospitals are going to do well under national health reform because more people will be insured.
And to be clear, this conversation that we're having about payment reform, what the federal bill does is create opportunities for innovative models. It's not imposed down. It's new opportunities to experiment, to innovate, and then we're having a very robust state conversation about, do we want to take advantage of those, maybe as a whole state? Do we want, so just to be clear, there isn't really anything in the bill that mandates doing this. So
let me speculate. One thing you may see in your ICU, which is right now, if somebody gets readmitted to the hospital makes extra money on that. They're not penalized. One of the ideas being talked about is some sort of, not a taking it away, but a little penalty on hospitals that have high rates of readmissions, patients who are discharged and come back. And often that's because they were discharged too early, or there was no planning, there was no discharge planning, there was no follow-up care. And now the hospital, if they're going to lose money for a readmission that could have been prevented, not for readmission somebody gets hit by a car the next week, that doesn't count, but somebody who comes back for something that honestly, reasonably could have been taken care of in the hospital, that means the hospital's going to spend a lot more time to make sure the patient is ready to go home and knows what to do when they come home. And that's, I think, going to make your job a little less stressful, I would think.
Well, let's thank our panelists. And before you all leave, I want to thank Amy Anderson for her leadership in putting this together. And then she would want me to tell you, fill out your evaluations. And have a safe trip home.